Welcome to the recorded version of the Grantmakers and Aging web seminar, Building a Movement to Transform Advanced Illness Care, featuring Ann Monroe, President of the Health Foundation for Western and Central New York, Tom Koutsoumpas, Executive Director of the Mintz Levin Center for Health Law and Policy, Bill Novelli, Professor at the McDonough School of Business at Georgetown University, and John Feather, CEO of Grantmakers and Aging, from March 26, 2013. This event was made possible by a partnership between Grantmakers and Aging and the John A. Hartford Foundation. Technical and production support is provided by the American Society on Aging.
And at this point, I would like to turn the floor over to Grantmakers and Aging CEO John Feather, who's going to guide us through this session. Welcome, John.
Thank you, Steve, and Happy New Year. This is our first webinar of 2013, so I want to welcome everybody to this edition of Conversations with GIA. As Steve said, I'm John Feather, the CEO of Grantmakers and Aging, and I'm delighted that so many of you have joined us today. Before I start, I want to thank the John A. Hartford Foundation of New York for providing continuing support of this webinar series. I also want to thank the expert team at the American Society on Aging for providing technical and production support for the series. Before we get started, I wanted to ask a couple questions to frame the issue and also test your knowledge. So, Steve, if you could bring up the first poll question. The question is, what percentage of seniors lose their entire assets during the last 5 years of life because of the cost of advanced illness care? And the answers are 5, 10, 25, or 50%. So if you would just answer that poll. All right. Most of you said 50. The answer is actually 25%, but I think you have the sense that many people struggle with the financial aspects of advanced illness care. And can we have the second quick poll question? What percentage of Americans consider themselves prepared for dealing with issues of advanced illness care? And once again, 0, 25, 50%, or 75%. And our results are? Well, you got it right on the nail. It's a little less than 25% consider themselves ready to deal with this. And we, as Americans, are living with advanced illness, and family caregivers are often not asked about the care they want and are offered little help to make good decisions, creating physical, emotional, and financial hardships on patients, families, and caregivers. Today, we're going to be discussing supporting and facilitating national and regional strategies to create a movement to tackle one of America's greatest challenges, breaking through the cultural, health system, and policy barriers so that people living with advanced illness receive the right care at the right time and place. We're glad to have three experts with us today to talk about this important national issue and the ways in which philanthropy can be involved. All of them are part of the Coalition to Transform Advanced Care, which we'll be hearing about a great deal today. First, Ann Monroe, who is the president of the Health Foundation for Western and Central New York. Tom Koutsoumpas, executive director of the Mintz Levin Center for Health Law and Policy. And Bill Novelli, professor at the McDonough School of Business at Georgetown University. Welcome to all of you.
Thank you.
Thanks, John.
Bill, let's start with you as we move to the second slide. As we had mentioned, advanced illness is a critical issue of importance to many. But we should probably start with a clear definition. What do you mean when you talk about advanced illness?
Well, John, as we all know, as we go through life, anybody can become seriously ill. Anybody can have advanced illness, even children. But for the most part, when we think about advanced illness, we're thinking about older people. And the advanced illness generally occurs when one or more conditions, usually some sort of chronic disease, become serious enough that their general health and their functioning, their daily functioning decline, and treatment begins to lose its effect. And this is a process that generally continues to the end of life. So when you think about the whole continuum of life, that's generally where advanced illness is said to begin. But in some cases, people can become seriously ill at the point of a diagnosis. So we've got to cover the whole continuum when we think about it.
Okay. If we go to the next slide, what are those challenges that we face in meeting the needs of those with serious progressive conditions?
The basic challenge is that there's a huge gap between what people want when they think about being seriously ill and what our society and our health system gives them. And when people enter into this difficult terrain, generally speaking, they are not asked what kind of care they want. Their caregivers are not asked. And they enter into a kind of a maze, if you will, of the healthcare system, with things being really fractionalized and siloed, with care difficult to figure out, having to make tough decisions in a time of crisis. And so, as I say, the gap between what people want and what they get is a very broad one.
Okay. So as we go to the next slide, what is it that individuals want? I know you've done a lot of research on that. So what have you learned about what Americans' attitudes about what's important in this arena?
Well, there is a lot of research on the subject, John, and generally what people say is they want to be at home. If they're in a state of advanced illness, they want to be at home with their families and their loved ones. They want to have their pain managed. They want to have their spiritual needs addressed. And probably above everything else, they want to make sure that they don't impoverish their loved ones as they go through this terrible process. So that's generally what people want.
So let's go to the next slide and see what it is that people actually get.
Well, as I said earlier, they get a very different thing. What they end up with oftentimes is a situation where they're in great emotional distress as well as, of course, physical distress. The care is fragmented. They're not really prepared to deal with these issues. They may have no advanced directives. They're not quite sure what the clinical team is telling them. And oftentimes, people end up in intensive care units. They end up being recycled through the hospital multiple times. And it's a state of aging and illness that oftentimes ends in a way in which people are dying in pain, in isolation, and without their loved ones around them.
Well, as we know that there's this challenge and difference between what people want and what people get, as we move to the next slide, I know that you feel that this issue it has a need of urgent attention. And why is that?
Well, there are many reasons for this. We are a rapidly aging society. And as people get older, they use healthcare more. They tend to have more of these chronic diseases, more of these life-limiting conditions. And so the population of people who are in serious illness or advanced illness is growing fast. And then the second reason basically is that technology is advancing. And while technology has been a great blessing for us in our lifetimes, now we're at a stage where technology can keep people alive, and I've used that word in quotes, a lot longer than anybody would wish. And so you've got this combination of an aging population, of advanced technology, of a really expensive system that isn't working well. And the whole combination of these things means that things are going to get worse before they get better unless we do something about it.
Before I turn to the last slide with you, Bill, I wanted to remind our audience that you can enter questions for our panelists at any time. We'll be addressing those after we've run through the slides and their initial presentation. So all you do is pull up the box in on your screen in the blue area under questions and just type that in, and we'll be using those as we come towards the end of our session. But Bill, as we move to the next slide, why is now the time? Why do we need to do this right now?
Well, John, as you know, the boomers are coming into their older years. So there are 78 million people in this huge population cohort. And the oldest of the boomers is now 67 years old. They've basically helped their parents through advanced illness, and now they're facing their own mortality. And so the boomer population is known as a feisty lot. And they are unlikely to accept the kind of fate that their parents had before them. So we see the boomers as an opportunity. We see the fact that healthcare is being reformed, or at least trying to be reformed, as another opportunity. We think that everybody has a personal story. Everybody wants to try to do something about this issue. Everybody realizes how difficult it is. And you know, if you bring this up with anybody, a United States senator, a doctor, a housewife, anybody, they want to tell you their personal story about their loved one and how difficult it all turned out to be. So for a variety of reasons, reasons of aging, reasons of cost, reasons of the boomers, of technology, now's the time to get this job done.
Thanks, Bill. Tom, let's bring you in at this point as we move to our next slide. What is being done about these daunting and long-standing challenges?
Well, thank you, John, for asking about that. This is really an extraordinary time, as Bill said, and an important time. And we began by addressing this, or beginning to attempt to address this, by creating the Coalition to Transform Advanced Care. And the coalition is an extraordinary group of diverse stakeholders. We've formed it in a way that focuses on 4 primary issues: clinical models, policy advocacy, public engagement, and professional education. We also have within the group a work group focused on faith and diversity, as well as the employer-employee arena. We recently had our national summit here in Washington, where we brought over 400 leaders together from clinicians, policymakers, faith leaders, employers, consumer groups, and many others to come together to talk about this problem and to talk about the solutions and how to move forward. It was an extraordinary meeting, and what we really learned was that during the process, harnessing the power of the personal stories and showing people that good models that exist is a great way to address this issue by looking at those models, hearing these stories, and understanding the passion with which we're approaching this. We also talked about policy options, and we brought together a bipartisan group of senators. And I think it's interesting in this era of partisanship that we were able to bring together 4 United States senators who were from diverse states and diverse backgrounds to come together to work with us and to show support for the kind of things we're doing. We're looking at the clinical models and looking at the best practices, looking at public engagement, looking at issues with employers, and we're disseminating information and developing strategies to address these issues.
Well, tell us a little bit more about the Coalition to Transform Advanced Care, or CTAC as everyone calls it. What's the vision and mission of the group as we move to the next slide?
Right. Our vision is that all Americans with advanced illness, especially the sickest and most vulnerable, will receive comprehensive, high-quality, person- and family-centered care that's consistent with their goals, values, and honors their dignity. The vision is that all Americans who have advanced illness will be able to access high-quality, patient- and family-centered, person- and family-centered care within their communities, so that you don't have to be lucky enough to be living in an area where there happens to be a provider that's doing advanced illness care delivery, but that wherever you are, that you'll be able to access good care. Our mission is to transform advanced illness care by empowering consumers, changing the healthcare delivery system, improving public and private policies, and enhancing provider capacity. As Bill mentioned, as we go into the next few years, the aging baby boomers are burgeoning, and their needs will be extraordinary. We need to get this right, and we need to develop an advanced care system that addresses their clinical, emotional issues and supports them in a way that's consistent with their values and their goals.
As we move to the next slide, who is involved in the effort at this point?
Well, I think, that's what's so exciting, and I think that's what makes this such a unique group in Washington. We have an extremely diverse group of stakeholders. We have well over 100. We actually have almost 140 participants. We have consumer groups. We have providers. We have hospice programs, home care programs. We have all sorts of diverse stakeholders that really are focused on solving this problem. When we came together, and as you know, in Washington, things can be so partisan, and even amongst the provider and payer community. But what we said is that this problem is bigger than all of us, and we needed to bring together the faith community, the consumer community, those who are providing care, those who represent those who are receiving care, to really look at this together and put our partisan self-interest aside and work towards a common goal. And that's what we've been able to do, and that's what we're so excited about. I think that the example of the diversity at our stakeholder summit validates that with the number of people, but also the various backgrounds and groups that they represented to come together to participate. So it is an extraordinary group of very diverse stakeholders.
As we move on to the next slide, what do you see as the most important functions of this coalition?
Yeah, clearly our primary focus is really analyzing and spreading the best practice delivery models that ensure high-quality, coordinated care across all settings. When we began this process, we learned very quickly that there are some extraordinary programs that exist around the country, and our goal was to look at those programs to develop a best practice model or models consistent with those programs, and then begin to disseminate information about that across the country to test those models, and then to begin looking forward to changing the delivery system to make sure that they're implemented. So disseminating innovative and interprofessional education is another arena. As I mentioned, one of our work groups is professional education, making sure that clinicians and healthcare system leaders are looking at how to improve quality and shared decision-making and improving medical care. So focusing on medical education and professional education. Advocating, looking at federal and state policies, looking at the regulatory arena, administrative policies, to see how they can be changed to make sure that we can improve care for those with advanced illness. And then, of course, undertaking and supporting public engagement, public education, making sure that people know that there is a better way to receive care. When you start talking about these personal stories and you understand what people go through with their parents or their grandparents or their loved ones, they immediately understand what we're talking about. And so getting the public engaged to demand better care for people with advanced illness is an important task as well. And then we're looking at and working with employers and the employer community to make sure that productivity, which will be clearly affected by the caregivers and the stress on caregivers, that there are ways to support that community as well. The faith-based community, so that we can assure that the faith community is engaged and those with those of diverse populations have their needs met as well. So those are the kind of things that we're doing as we approach this problem.
As we come to my last question for you, Tom, I want to remind our audience that you can provide questions for our panelists at any point just by going to the question section on the box that's on your screen and typing that in. I'll be asking the questions a little bit later. So if we move to the next slide, Tom, what are some of the most important? I'm sorry. What do you see as some of the next steps in the process?
Sure. Well, we're very excited about these next steps. I mean, we're developing a national roadmap with the specifics needed to transform advanced illness care. So we're really looking at that carefully, and we'll have an extraordinary roadmap that will help guide us as we move forward with this enormous process. Another exciting thing that we're doing is we're analyzing and we're promoting clinical and community models that work with strategies from the health systems and other clinicians that are doing this in extraordinary ways. And so the goal is to not just disseminate information, but really promote those within the communities and test them within communities as well. So that, again, if you're in rural Indiana or if you're in New York City, that there'll be models that will be available and that will be engaging with those in various communities. We're going to launch a consumer website with content from our members and inform the public about choices for decision making when serious illness occurs. I think we all can relate very, very clearly to when our loved one is informed and understands the serious nature of various illnesses that they may have. The inability to know what to do is extraordinary for not only the person but the family members and the caregivers that support them. So launching a consumer website with detailed information and a guide is going to be extremely important. And then we're convening community leaders in public and professional education, in policy and advocacy, with key partners of the faith-based and diverse communities as well. And that's another clearly very important element of this, making sure, as I said before, that the faith community and communities of diversity have their needs addressed and are included as we look at better ways to provide high-quality, person-centered, coordinated advanced illness care. So those are some of the most immediate things that are coming soon as we move forward with our work.
Well, thanks, Tom. As we move to the next slide, Ann, I'd like to bring you in. You're the president of a place-based regional funder, and so you're interested in improving the health of your particular region and geographic area. But I know that you're also on the board of the coalition here on CTAC. Why do you think local and national philanthropy should be involved in such an effort?
Well, thank you, John, and thank you, all of you who are participating today. We look forward to your questions. It would seem on its surface to be kind of an interesting relationship to have a regional foundation focused on the people within that region and a national effort. And my slides today really give you about 10 different reasons that we should engage, but let me start that by saying that I think that what we need to have is a synergistic effort at both the national and the local level. The national effort needs to help us on issues of national policy, of large scope public engagement, etc., and identifying ways that the national interest can both be piqued and the capacity built. And we on the local level have much more information and are useful to the national effort about what really works in communities. And I think that the appealing thing to me about CTAC is that we can work as hard and as much as we can on the local level, but without a kind of national coordinating body that can bring all of the different perspectives together and provide some alignment and resources to us at the local level, we're pretty much on our own. So that's why I found that joining CTAC was beneficial to our regional and local efforts as well. But just to move on to I did this in a not unique way, but some top 10 reasons why we as foundations, local, regional, and national, need to engage. It's very clear that the people we care about and their caregivers are not getting the quality of life they deserve. And we know as funders in aging that quality of life is much more than just medical care. But as long as medical care is sapping the resources that can be used for other quality of life issues, it's going to be very difficult for us to really reach true quality of life. We don't have to ask people anymore whether they're satisfied. You saw on the slides today that we certainly don't need any more polling. We know where people are at, but what we do need as regional and local foundations is some kind of framework to orient ourselves and our board when we're trying to decide on where we should invest our programmatic resources. And I'm really looking to CTAC to help build that framework that pulls in all these different pieces so that we can find our way on what I would call the mall map. We are here. That framework is critical. On the local level, ACOs are coming to be, at least in New York, health homes and primary care medical homes are certainly from us and from others on how to craft their policies covering advanced illness care services. Because my concern, and I would expect yours as well, without a good paradigm for understanding and measuring the effectiveness of advanced illness care, cost-cutting alone will rule the day. And cost-cutting by itself is not going to accomplish the quality of life that people and their caregivers are looking for. Next slide. Next slide.
Can we get the next slide? Keep going, Ann.
Okay, there we go. I think by crafting this umbrella at the national level and having that umbrella kind of permeate, we can provide a common strategic table for different perspectives. There is not a common language or a common sense of collective impact currently among the various parties that are important in achieving quality of life. And this paradigm, this umbrella can provide that, and can also for us at local and regional foundations be a springboard for coalition building on other issues of importance to aging in the community. Another thing that's happening at the national level is we're seeing responsibility for the dually eligible, meaning they're eligible for Medicare and Medicaid, which are primarily the poorest among us, moving that responsibility from the federal government to the states. And when that happens on a state-by-state basis, there's a risk of widely divergent funding and programmatic efforts. We can see that now in what's happening just with Medicaid. Some states are expanding, some states are contracting, some states are accepting federal money, some are refusing it. And I think if that happens with these efforts around seniors, we will see wildly divergent and not always good approaches to advanced illness care. And those of you who are involved less in the treatment of seniors or the care down that continuum that Bill talked about, but rather you want to focus on the prevention side of all of this, my concern is that those efforts to keep people well can be undercut by disrespectful, overly expensive, and intrusive advanced illness care. That can preoccupy families and preoccupy communities as they look to how to manage that care, which will put the prevention efforts that others of us are working on kind of on the back burner. Lastly there, I think you know that it's really something, this idea of advanced illness, as much as we'd like to think it won't touch us or our families, the power of the story, the power of our own experience tell us that we too are going to need this kind of care on a very personal level. And I view the role of a regional and a local foundation to highlight those issues that are of the most critical and painful importance in our community to see if we can do something about this. Now, so it's not us, or we, I guess, who is going to do this? Who is going to hold the community in our hands and talk about what's important to them, to the people who live there, and their caregivers? Now, some of you would never consider funding a group like CTAC because it's a national group, and I certainly respect that. It's a heavy lift for us. But I do think that being connected with the national project, understanding what they're finding, and adding our collective philanthropic voice to what they're about is critically important to achieving the overall goals of this. We have Congress people, we have legislative people within our own district. How do they feel about this? What do they see as the strategy for these things? We can be very informative at the local level. How do our experiences and our stories help sell and the importance of looking at an overall strategy for transforming advanced illness care? So whether you're thinking about funding at a local, regional, or even a national level, and whether you're thinking about being community leaders in this effort, I think in both ways, joining and understanding what the coalition is doing is going to be very important to all of us in the work that we do. So I'm going to stop there, John, unless you have other questions.
Well, thanks very much, Ann. It's very, very helpful and very insightful. And at this point, I want to begin turning to the questions from our audience. And remember that you can type in your questions at any point in the box that you have on your screen. We have a couple of things, and I'll direct my first one to Bill and to Tom, and that is. Let me try to paraphrase this a bit. If this is an issue that has been around for a long time, and many people of insight and vigor have tried to address it in the past, what do you think is different about this effort that makes you believe so strongly that it will be able to move forward in a way that others have not?
Good question. First of all, there has been an awful lot of work done, and many people have been working on this for a very long time. And that work has not been in vain. Our job, as we see it, is to build on that, to stand on the shoulders of those who have done all that work. So we're not trying to reinvent this. What we're trying to do really is to catalyze it, to inject some real vigor into the movement. That's number one. Number two, John, as I said earlier, I think the boomers are a big difference. They're a big difference because of their size, because of their aging, because of their attitude. And I also truthfully believe that CTAC is a big difference because what we represent at this point is an opportunity to really disseminate strategies and innovations, to be a catalyst, to be this big nonpartisan, big umbrella, big tent that can help to pull things together and get this work done. So I think the time is right. And one of the things that Tom talked about earlier was how big and robust this coalition is. And what I would add to that is that these are not just organizations, companies, organizations, and so forth that have loaned their name to this movement. These are people who are really working. They're engaged in those working groups that Tom talked about, engaged in those committees. They came to the summit and really pitched in. So I think we have quite a bit of momentum right now, and so I do think this is the time.
And I would just add to what Bill said. I think what's important is the extraordinary work that has been done in the past has really led to this point. And I think now we have, and we're seeing a lot of different kinds of groups of folks getting involved in this that are recognizing how important this is going forward. So I think what we've been able to do is, building on the past and including that, as well as looking at new folks and new kinds of groups to engage, and all of us coming together to move this forward is really, I think, what's unique about this and how it blends the past with the present and together moving into the future.
Okay, thanks.
If I could add to that, John?
Sure, please.
I think that the other reason why this is different now is the timing in the sense of local health systems having to rethink what their role is. Take readmissions, for example.
Right.
It used to be fine to come back into the hospital every couple of weeks to manage your congestive heart failure. And now hospitals are being penalized for those kinds of readmissions, which opens the opportunity for dialogue on what should the SNP care system look like instead. And I think that's a new thing that we really have to come to grips with, because the financing model for care is changing, and there's nothing like changing financing to capture people's attention.
Well, and if I could stick with you, Ann, for a second, you had mentioned the ACOs. Just to make sure that all of our audience understands what that concept is and how that fits into the notion that you just discussed. Would you talk about ACOs and their role for a minute?
Sure, and I'm sorry for the acronym. ACOs are accountable care organizations, and the federal government is licensing or authorizing them all over the country. And the idea is they will take accountability for a population and for the care needs of that population. And that means that it is now in their self-interest to provide the most effective care at the least cost. As I said earlier, I think the challenge is, what is the paradigm for advanced illness care that makes sure that the essence of what's important to patients and their families gets retained, and it's not just looked at on a cost basis. For example, how much will they be providing in the home in terms of advanced illness care compared to providing it in the hospital? And the risk we run without some dialogue there is that they may not do anything in the home, but just keep people out of the hospital. And I think that's not going to be in the best interest of our population. So as they develop, I think it's critical that the dialogue around advanced illness care is a robust and ongoing one with them.
Great. Tom, I'll direct this question to you, but we'll then ask everyone else's point of view as well. The question is, end-of-life care, advanced illness care, palliative care, and hospice are often, too often conflated, and I would add confused, in policy and practice discussions. How are you helping to both articulate the critical differences while uniting the stakeholders in support of CTAC's agenda?
Well, that's a great question, and we're really making an extraordinary effort to develop appropriate terminology so that there is no confusion. Clearly, hospice is a care delivery model that's engaged for people with a 6-month prognosis. Palliative care is pain and symptom management, and of course, a broader focus on symptom management. Advanced illness care delivery, we believe, encompasses all of that, so that we look at the patient, the family, their needs in total, and palliative care is a component. Certainly hospice care is a component when the patient reaches that point of diagnosis. And so what we're trying to do is clarify terminology and disseminate the information accordingly so that there is a clear understanding. I think what we've discovered, and we've worked with a number of groups that have done a lot of research into the language that people do understand. And what we've determined is that people do understand very simply the term advanced illness care. And so as we talk about it, it's very easy for them to understand because it's a simplified language that people can relate to. So we're very careful with this, and we absolutely recognize the importance of the different terminologies and the different definitions, and we're trying to bring them all together under one umbrella.
Bill or Ann?
John, I think that sums it up very well. When you think about this continuum that I was talking about earlier, we see this as a very broad continuum, and in many of those models that work, what clinicians are doing is they're trying to assess where patients are on that continuum and make appropriate decisions. So the same decision wouldn't work for every patient. And of course, if a patient has a diagnosis of a serious illness, then that begins the process right there. But absent that, we're leaving it up to clinicians to make that determination. But we see it as a broad continuum.
Ann?
Yes, I would just add that this discussion highlights for me why we need a paradigm about all of this, because many of us at the local level get grant requests from hospitals, grant requests from home visiting nurses, and grant requests from palliative care programs. And we need a framework within which to place all of those things so that they're not perceived as isolated silos of care, but part of a continuum. Maybe our community doesn't need more hospice work, but it needs more downstream work in homes. And so we need to be able to have that broader discussion in order to best invest our programmatic resources.
Great. I'd like to stick with you, Ann, if I could, because we have a question about appropriate funding of these kinds of efforts. You gave in your slides some insights into why you think this is important. Do you have examples of good foundation funding or other kind of grantmaker funding that would be appropriate to local foundations?
Well, I can speak for our own foundation and for several others, but we've had a major initiative on advanced care planning, and it's called Sharing Your Wishes. And we've developed a county-based coalition to look at integrating advanced care planning into the fabric of the community through churches, through community groups, and then look to make sure that those advanced care directives, if you would, are being honored in the system and what some of the barriers might be. So we've done that. We have funded a lot of work around caregivers and empowering and strengthening caregivers to be able to speak up for what they need for their family members. We've used the Powerful Tools for Caregivers program to train people in the community to work with caregivers. Additionally, we've done work on transitions of care so that there can be a transition coach to help people through this process. And then lastly, we're now looking at some of the triggers of decline that create the need for advanced care. And so we're moving a little more into prevention in those things, looking at fall prevention, looking at medication issues, and some of those things. But those are things that can be done at a local level that really increase both awareness, knowledge, and capacity to begin to attack and address some of these other issues.
Thanks. Tom or Bill?
I think that spells it out very well.
I would add, if I could, just, and I didn't mention it, but it's critical in the CTEC context, is relationships with faith-based organizations. There is a spiritual component to all of this, and it needs to be reflected in the local work as well. And that makes churches great partners for us on this kind of work.
Okay. Thank you. I'll start with this one with Bill, and we'll go to our other panelists. What are the most important aspects in creating a national model that will be sustainable? So not just implementable, but sustainable. Is it in program delivery and consistency, data collection, funding, or other issues? What are your thoughts?
Well, John, you know the answer to that. It is yes.
Yes.
Yes, it is. In order to create a national movement and have it be sustainable, so that we end up with real sustainable, positive social change, we need to do all those things. So from a CTAC perspective, we've got a strategic plan, and as Tom said, we're now developing it into this roadmap as a result of the summit. We see that there are really, we think, 4 key intervention areas. One is public engagement, and we really need to get the public to understand that they need to ask questions. They need to plan in advance of serious illness. When serious illness strikes, they need to understand that they can be told and should be told all the options, including the option of no care. They need to ask the right questions, and they need to be supportive of system change. And so public engagement is a key part of it. Tom earlier mentioned the idea of professional education and support. You know, clinicians want to do the right thing, but they need help. They need help in terms of communication especially, but pain management and other things. We really need to take these models that are already working and figure out what is the common elements among them, what's the common architecture, so to speak, and then promulgate those models across the country so that people can basically adopt them based on what kind of a health system they have in their local communities. And then to make all this possible, we've got to have good policy advocacy in order to work on reimbursements and other elements of those interventions. And then to make any of this possible, of course, we've got to have the funding that enables us to do all this. We've got to have good metrics, both a national baseline and then metrics as we go forward in each one of these areas. And so, you know, the way we always think about it is it's got to be synergistic. We can't do this in some sequence. It has to be done all at once, and each one supports the other element.
Tom?
No, I think Bill's described it exactly the way we believe it's critical for really moving forward with this. And I think Ann made mention of this as well. But the most important thing here is that we have person and family-centered models that increase quality and really provide the kind of care that people want and deserve. And so all of the components that Bill described are important in making that sustainable for the long term. And that's I think that's really what's critical here as we try to move forward with adopting these models and engaging the public and creating system change, and as well as financial support.
Ann, anything to add?
Yeah, I just add that I think when I think about what is the greatest risk to CTAC succeeding, I think it is because it was unable, in spite of its own desires or wishes and capacity, to connect with what's already happening at the local level. And I think that that's critically important. I know the desire to do that is there. And I would really make the pitch to John, to you, to kind of be a conduit between what's happening at the local level and what's being proposed at the national level so that it's fairly seamless. Many of my colleagues have been working in this for a long time. And those strategies, some of which have worked and some of which haven't, need to inform this national strategy as well as be informed by it. So I would think that Grantmakers in Aging might be a perfect partner to CTAC in channeling the voice in both directions. Because without a duality of voice, I think we will sub-optimize what we're each trying to do.
And this, Tom, I would just agree completely. I think, Ann, that was beautifully said. And I think what we've found, obviously, is that it's within the local communities where we're seeing these extraordinary models and where we can see this high-quality care being delivered. And so really working with the local communities and adopting and getting information from their approach, and then looking towards a national strategy to assure that those local communities have access to that care wherever they may be is so critical.
Well, that's certainly a tremendous challenge, Ann, and we are trying and will continue to try to meet those responsibilities. There's no question that this is the critical aspect of this. As we come to the end of our hour, I would like for each of you to spend a few moments sharing any final wisdom and advice you have with our audience, any requests that you may have of them, and so on. And I'll start with Bill.
I guess I would say two things, John, one of which has already been said, but I want to emphasize it, and that is whether you go up on the Hill and talk to United States senators or you talk to state legislators, whether you go to the CTAC National Summit, wherever you go, when you bring up this subject, the first thing that people want to talk about is their own experience, their experience with their mother or their father, with some loved one. And that's really, I think, the glue that binds us all together in this endeavor. That is really powerful, and we can build upon that. And of course, those of us who are in CTAC have personal stories just like everybody else. And then the second thing I would say is that those who participated in this webinar and had questions or are thinking about it, please get in touch with us. We'd like to hear from you. We'd like to know if you have any more questions. We hope you'll visit our website. This is an opportunity, and what we need is the wisdom of people who have been at it for a while, who have a local perspective, a regional perspective. We can benefit from that.
And Bill, could you give us the web address again?
Well, John, it's on the first slide, and it's thectac.org.
Okay. So it's easy enough, ctac.org.
Thectac.org.
Okay, I'm sorry, thectac.org.
Yeah.
Okay. Tom?
Well, and I would just echo Bill's sentiment, and I would say, again, thank you for the opportunity. It's really an honor for us to be able to participate with you and with the folks on the call today. The experience that all of you have in this arena is so important as we work together to really move and change. And so we're very grateful. We're very appreciative. We look forward, as Bill said, to hearing from you and working together to move things forward and to change the way people with advanced illness receive care. So thank you so much for this honor and this opportunity.
Well, you're quite welcome, and we're honored as well. Anne, would you like to add your final thoughts?
Well, I just, again, want to thank everybody. As local and regional foundations, we sometimes struggle with how to engage on a national level when you don't have a policy staff or you don't have, the access to the kinds of things that I'm hoping CTAC will be able to bring to all of us. As one of you, I certainly would be available to any of you if you want to talk about relationships with CTAC and how foundations might engage. And I just leave this thought. Even if you don't fund in this area or you can't imagine yourself ever funding in this area, any one of us who's close to or passionate about engaging needs to recognize that this part of our system is really letting people down. And so, as I said, even if it's not on your top agenda, I'd ask you to keep your finger on the pulse of what's happening with this for the people that we care about. And again, just thanks for including us.
Well, thank you, and thanks to all of our panelists. I want to thank Anne Monroe, Tom Koutsoumpas, and Bill Novelli for joining us today. Thank you all for everything that you do to make life better for older people and their families. We also want to thank the John A. Hartford Foundation for their continuing support of this webinar series, as well as the American Society on Aging for their technical expertise. And finally, I want to thank all of you for participating in today's webinar. Have a great day.